My name is Sarah Brewer. I'm the Executive Director of Face to Face, hosting this event tonight. Our mission is to end HIV in Sonoma County. And if you're not familiar with Face to Face, we were founded in 1983. We were a grassroots response to the AIDS epidemic. People were dying and they were being ignored, discriminated against. A pair of ladies decided that they needed to do something about that and show up for people so that they weren't alone. They could die with dignity and with love and respect, face to face. And today we continue with that approach. We've evolved over the years. This is our 40th anniversary. With effective treatment, people... Yeah, so we've evolved over the years. We have a very robust care team that provides support for people living with HIV. We provide housing support, financial assistance. We have support groups, case management. The majority of our clients are living at or below the poverty line. And then over the years, we've been building a very robust prevention program. And that includes HIV testing. We have access to PrEP, which is the medication to prevent the spread of HIV. We do outreach, we do education, and in 2015 we started a syringe exchange program where now we provide sterile injection equipment, smoking supplies, Narcan, fentanyl, and now all of this we do on an electric mobile van 4 days a week out in the community as well. That was a huge dream of ours. I'm very happy to say that all of that is for free. And so we're very grateful to our supporters for allowing us to provide those services. And a lot of them are also confidential or anonymous. Last year alone, we distributed almost 900,000 sterile syringes, and we got about 80% of those back. We also gave out almost 6,000 doses of Narcan, and had reported to us almost 4,000 reversals. That's 4,000 lives that were saved. As I said, we also offer fentanyl test strips and now xylazine test strips. One of the things that we're really proud of too is that we're involving people who use drugs in our services, and especially with our van, helping us identify how we can reach people, where people aren't getting services, and how do we really effectively meet their need. I'm also very happy to share that we have the first 24-hour, 7-day-a-week free vending machine with harm reduction supplies in our parking lot. And so not only does it have access to sterile injection equipment, we also have COVID tests, safer sex supplies, and we're so happy about this. So we're hoping to get more in the community as well. We're also implementing syringe kiosks for disposal throughout the community. So I'll just put a little plug out there if anybody's interested in hosting one, come talk to us. We're here tonight to talk about harm reduction and the harm reduction services that we provide. It's important to us to host this discussion because I think that there's a lot of misconception about harm reduction, so we're grateful to you for being here tonight so that we can learn more. Harm reduction recognizes that for better or for worse, people use drugs, and harm reduction works to minimize the harmful effects rather than criminalizing or condemning them and the people who use them. What we're going to talk about today, harm reduction is a wide spectrum of interventions, whether it's not just about abstinence, it's not about treatment, it's about how can a person use drugs safely. I think that there's a misconception that harm reduction promotes drug use, and that's why we're having these conversations, because it doesn't promote drug use. It promotes the safe use of drugs. And as we said, a person can't get well if they can't get into treatment if they're dead. And there are a lot of infectious diseases, and we're trying to prevent the spread of those diseases so that a person, wherever they are in their life, we can meet them and we can help them. And again, meet them with love and dignity and respect, without judgment and without coercion. We all practice harm reduction, if it's brushing your teeth, if it's wearing a seatbelt, so the concept isn't new to us, but I think, as we're talking in the context of people who use drugs, there's obviously a lot of discrimination and a lot of stigma. And so we're working very hard to do away with that. And so thank you for being here and for being a part of that tonight. I just want to share some statistics too. I think it's important to recognize, let's do this. How many people, if you're comfortable with a show of hands, how many people in this room have been personally affected by drug use or overdose or something? Yeah, me too. Since 1999, more than 1 million people in the US have died from a drug overdose. Currently, it's 96,700 people die every year from an overdose, and opioids are a factor in 7 out of 10 of those deaths. Sonoma County's overdose rate is well above the state's average, and we are the second highest in the Bay Area, second only to San Francisco. So we've been doing a lot of work, but we have a long ways to go. But I think that that's why we're all here tonight, is that we all recognize that there's something that needs to be done, and we're trying to educate ourselves and trying to do something, see what we can do, and to come together to do that. Harm reduction is gaining a lot of traction. It's becoming a bit more mainstream. I think historically it was somewhat controversial, and I think that's one of the things that we want to talk about, because we're trying to do away with that controversy. As far as we're concerned, there is no controversy. And we're also grateful to be operating in the state of California, which is very supportive of harm reduction programs and has made considerable funding available so that, we'll hear more about this, but so that we can do this work, so that we can expand and we can work together. The National Harm Reduction Coalition and the California Harm Reduction Initiative provides incredible capacity support, technical assistance, and keeps us connected so we can share best practices and work together, not just in California, but nationally as well. So we are grateful to be a part of that. And I think as parents, as members of our community, we all want to do something. So let's get to work. I'd like to start by introducing, we have an incredible panel here tonight, and we are very, very fortunate to have Laura Guzman moderating this for us. She is the Executive Director of the National Harm Reduction Coalition. I'm just going to go ahead and say she's a badass. She's a human... well, just get ready, because we're going to read the bio, so I think we're all going to be flushing. Laura Guzman is a human rights activist and a nonprofit leader with over 30 years of experience serving, building capacity, and organizing across communities in the intersections of harm reduction, homelessness, health, and housing. She's the Executive Director of the National Harm Reduction Coalition, joining in early 2020 as the Senior Director of Capacity Building and Community Mobilization to oversee California's work. In the role, she oversaw the implementation of the California Harm Reduction Initiative, which I shared we were a part of, the first and largest investment in syringe service programs funding for the state of California. I cannot emphasize enough how monumental that was. Huge. Thank you. It's just incredible. So the National Harm Reduction Coalition led Cheery by offering low barrier grant making, training and technical assistance, and data evaluation of 37 syringe exchange programs, syringe service programs, in collaboration with the California Department of Public Health and the Office of AIDS. And all of this successful implementation of Cheery has led to another round of funding in the amount of $61 million from the opioid settlement funding through 2027. Again, I cannot stress how monumental that is when traditionally there has been zero money available. She's a badass. Not just her. Prior to joining the National Harm Reduction Coalition, Laura was Continuum of Care Director for Everyone Home, leading the Alameda County 2019 Homeless Point in Time Count and the county's annual federal homelessness-related housing funding application to HUD. She's also the founder of the Mission Neighborhood Resource Center in San Francisco, where she directed for 16 years a harm reduction center that targeted Spanish-speaking Latino immigrants and offered drop-in services, community programs, behavioral and primary medical services to homeless single adults living in streets, shelters, and SRO hotels. Yeah. Laura is passionate about community participatory processes that include and elevate the voices of people impacted by poverty, racism, and the drug war, immigration laws, and homelessness in order to redirect and develop resources and services relevant to the communities she serves. She is also deeply committed to building collective and powerful cross-systems, grassroots coalitions to attain transformative system change and the liberation of all people. Born in Buenos Aires, Argentina, Laura holds a Juris Doctor degree from the New College of California School of Law in 1995 and a bachelor's in linguistics from the University of California at Berkeley in 1992. She currently serves as the co-chair of the Alameda County Healthcare for the Homeless Commission. Ladies and gentlemen, I present to you Laura Guzman.
Thank you, everyone. It's a truly an honor to be here. I love Sonoma County. I love Monterrey. I love the Russian River. I love Maryville. I love Lori Violet and Face to Face. So it's very honored to be here. And before I introduce the kick-ass panel that we have today, I wanted to, in some ways, summarize what Sarah was talking about, because when we talk about harm reduction, we really talk about a movement that started when people were dying of AIDS, people who used drugs, who nobody was taking care of them. There was no government, there was no funding. These were folks that ended up dying either on the streets or in the Ambassador Hotel, where I started my career in the Tenderloin, where we had 150 people dying of AIDS who nobody was taking care of by community. So part of the harm reduction philosophy is that community takes care of community. And so it was the syringe service programs, it was the people with HIV who were actually taking care of people who were dying, and people who used drugs, that were the ones who started to actually do the public health interventions that keeps people alive. So the Harm Reduction Coalition was actually born in the Bay Area, in Oakland. In 1995, the organization was born, and it happened that I had the privilege to be trained by all of those people that were rebels, I call it. They were the ones defying what nobody else wanted to touch. Not just reggae. There was public health not touching our folks. The stigma, the fact that they were injecting drugs, the fact that they were poor, they were black, they were brown, they were trans. So it is, for me, an honor to be in a movement and to also today have this conversation, because in some ways the call is for all of us. Now that we're seeing this incredible crisis that is really more related to systemic violence than it is to fentanyl alone. So we need to also self-educate ourselves again to know that it is the conditions under which most of our folks live, sometimes the very reasons why they might be dying of overdoses. They might still be living with Hep C that is treatable, but that we don't have the funding to treat them, right? So we still live in a system that doesn't care enough for our folks. So as a public health intervention, this harm reduction movement, the syringe service programs, we have at this point almost 40 to 50 years of evidence that it prevents hepatitis C transmission, HIV, skin infections, according to, making sure that people are not sharing needles. And I think that there's nothing controversial about something that we have shown works. What's controversial is the voices that actually minimize the impact of our work. I also want to say, perhaps because we're impactful, is that people are talking. So with that, I want to make sure that I let this panel to share more what harm reduction is all about, because I'm what I call a die-hard harm reductionist, and I'm so excited about the folks today here with us. So I'm going to let, actually, each panelist is going to share their name, pronoun, title, role, or whatever way they want to define themselves, and 2 or 3 sentences on why is harm reduction key to supporting communities who use drugs to stay alive and well.
Thank you so much. My name is Scotty King, he, him, and I joined this club that none of you ever want to join for a parent that lost a son to fentanyl. 1 year ago, he was partying with his friends, and I don't think he knew there was fentanyl in a line of cocaine, and he just crashed out on the sofa, and his friends left the house, and that was that. So if someone had had Narcan, he might be here today. So what I'm wearing is his photograph here. I went to Dia de los Muertos in San Francisco, and there were thousands of people proceeding through the mission with a candle, pictures of their loved ones they lost last year. This has about 300 faces, and these plus about 85,000 more perished last year. And if you look up close, it's too small, but they're the most bright, beautiful, vivacious young people you've ever seen, with a lust for life that they didn't want to end up in this photograph. And I'll get a chance to say a little more later, but I'm here to honor my son, to do whatever I can to help stop these needless deaths.
Hello, my name is Lori Violette. I go by she, her pronouns. I'm the prevention director at Face to Face. I'm very happy to be here today. Harm reduction for me means love. It's the simplest way that I can put it is it's just loving people, regardless of where they are in their life, regardless of what they're doing in their life. It's showing compassion and love. And that's important for us as humans to have that connection.
I'm Alexis, she, her. I'm a substance use navigator at Santa Rosa Memorial Hospital. Harm reduction, in my opinion, is imperative to the community because it is the foundation that supports the community that needs additional support in a place that is so stigmatized and harmful to the person at hand. And so I've seen in my own personal life the outcome for those who do not feel the support and respect that they deserve.
Good evening, my name is and I am a harm reduction specialist out of Office of AIDS, California Department of Public Health. And I'm going to do two things today. So I'm wearing two hats. I have a City PH Office of AIDS hat, and I will be sharing data and trends and things of that sort, but I'll take that hat off and then have my Loris hat on where I can share information from a personal perspective. I hope that makes sense. So in terms of like harm reduction, government hat, harm reduction, you talked about it, Laura. There is countless data, countless research that has continuously proven that the strategy works. And when I say harm reduction services, that's what I'm talking about. Harm reduction services, we no longer at the Office of AIDS consider continuing research. I hope that makes sense because we have such a robust body of research. And for me personally, taking off the government hat, harm reduction is important. It was said before as well, like this is something that we have done, that humans have done throughout time. A fancy researcher decided to name it harm reduction, right? Like there's so many ways that we can apply it to life. And from my perspective, and being a person who has been personally affected, I've seen my family negatively affected by the drug war, by being someone who is using drugs and not having resources or support. And for me, I decided to become a harm reductionist and do this work from a public health standpoint of infectious disease. But now we're getting to when we're thinking about the overdose, the fatal overdose epidemic, we're now needing to include the fact that we want to figure out ways or incorporate harm reduction strategies to keep people alive, right? So when you're thinking about the big threes of what we at the Office of AIDS are trying to prevent, we're trying to prevent infectious diseases as it relates to HIV, STIs, and Hep C, and we're trying to keep people alive now. And when you have a intervention, a strategy, a practice, a theory, a way of applying every action that you do in life to protect yourself, right? When you have that theory and you know that integrating it and implementing it into services in the community has an effect, and we're still facing pushback on that, it can get frustrating. I would say that. So that is why I'm here. I'm here to keep pushing back against that.
If I can also add that Ms. my partner in crime on the implementation of California Harm Reduction Initiative, so she takes the glory too, along with Face to Face too. She's my state nemesis. So we decided to do this as a fire chat and dialogue, so everybody gets asked a different question. So we're going to start with Scott. And the question for Scott is, what are some of the reasons why people use drugs? Why won't they just stop?
That's a great question. I wanted to tell you a little story. Thursday night, as I mentioned, I went to San Francisco to honor my son. He was born there and proceed in the Dia de los Muertos parade through the mission. And we walked behind this huge band of drummers. It was so soulful to be there with other people, also honoring it's the day when the veil is thin between this world and the next world. And to come home, we got in our car, and we were driving through San Francisco, and I looked over, there was a man that was just passed out. And we rolled down our windows and asked the people standing nearby. They said, I think he overdosed. I'm getting goosebumps because I put my emergency flashers on, I got out, cars were honking, and I got my Narcan that was in the glove box. And I went over, and this man looked like he was dead. And we did one shot of Narcan, one nose, and my mics. Can you hear me okay? He didn't move. He didn't breathe. I did the Narcan in the other nose, put him on his side, and he kind of started to moan a little bit, and then he took in a breath. It was the most amazing thing. And then he got up and trotted away. We were on the phone with 911. They were asking my partner they didn't seem too interested in rushing out. They were like, well, tell us what's happening now, and what's this, and what's that. They never once offered to, so I don't know what that's about. But we told him, well, he took off, and I drove home still shaking. But that's the power of Narcan, and if someone had been there with this little squirt bottle for my son, he might still be here. So why do people do drugs? Oh my gosh. My son, I talked to him that weekend. He said, Dad, I've got new friends. We're having so much fun. I feel so great. He had not been socializing a whole bunch. And so his cousin took him to this party. He was basically partying his ass off, having a great time. And he went to someone else's house. And I think someone said, hey, let's have another line of cocaine, and he didn't know. The fentanyl could be light on one side of the baggie and maybe more concentrated on the other. These are street drugs. And he passed out, and I think he died very peacefully, which is one consolation. But it was just, when my ex-wife called me to say, are you sitting down? Spencer died, and that still replays in my head over and over and over. It's just the worst thing a dad could hear. Now, I hadn't really heard of fentanyl, but I know that there are the cases that I've read a lot that, somebody gets one pill at a party to relax, and they die. I've read the accounts of parents going into the bedroom to find their son or daughter, cold. And I've also heard some people use those test strips because they want the fentanyl. They're addicted to drugs. It's much cheaper than heroin. And so why people do this is all over the map. And my wish is that we can look back in a few years. I know it took almost 10 or 20 years to end the opiate crisis. That was American-made opiates that doctors were prescribing like crazy. But there's got to be a way to stop these deaths. 85,000 is more than all car accidents and suicides put together. It's more than died in 20 years of the Vietnam War. And I was young, but we hit the streets to protest when all those bodies came back in coffins. But I worry our society is not revved up about this enough yet. And so I think people do. I think one of the answers is full employment, health insurance, ability to rent an apartment. I think people do drugs because they just want to be in heaven for a minute. They don't want to go there permanently, but they want to forget all the struggles. When I went to college, UC Berkeley was $200 a semester, and now it's probably like $20,000 now. or something. Yeah, it's too bad we're in a society where they're making education harder to get for our young people. You can't rent an apartment in Sonoma County. Oh, I got my 3-minute mark. I think hospice has been such a huge help. When I learned this word, grief education, I didn't know. I didn't know a thing about grief. I mean, my mom and dad had passed away. I was sad. It didn't touch what I felt for a young person in my family to die. And I'm getting professional help. It's the only reason I can be here. And I've committed, my son's spirit came to me and said, Dad, don't cry too much. You've got this wonderful life to live. Get out there. And I know that I live for him as well, as he's my guardian angel now. And I get to do things that his life was cut off short, that he doesn't get to do. So it's become a huge spiritual thing for me moving on. But that's my goal, is to continue to live, to honor him. I just completed 3 days of hospice training to be a volunteer, because they helped me so much. And I'm just so honored to be here with you all. And hopefully we can all go out of this room and take the message, take a box of Narcan and save a life or more.
So the second question is for Lori. What is the biggest misconception or misconceptions about harm reduction? Why is it so important? And what communities are in most need of this services in Sonoma County, and what are the gaps?
This is my thing now. Okay. Well, for me, there's really two big misconceptions about harm reduction. And the first one would be that people who use drugs don't care about their health. That's the complete opposite. People who use drugs care about their health, or they wouldn't come see us on a regular basis. They wouldn't ride their bikes for miles. They wouldn't walk for miles. They would not go without food or water for miles to come get supplies from us. So it's BS that people who use drugs do not care about their health. They do. Just making that clear off the top, that's one of the biggest misconceptions. The other is that it enables people. I hear often, if you're providing support to somebody who's using drugs, you're just enabling them. That show Intervention, if you all have seen that show, and how they say, well, you need to cut those people off. You need to cut your brother and your sister off because they're just going to use you. For humans to make any kind of healthy change in life or to feel loved and supported, they need to have connection with other people. They need to feel some compassion and some love. So harm reduction does not enable people. It actually does the complete opposite. It provides them with what they need to, if they want to make a change, to make that change. We do not tell people what they should do. We accept people for who they are and what they're doing. We're helping them to stay alive and helping them to know that they're important to us and provide hope to them. If a person doesn't have hope in their life, what do we have? What do we have if we don't have hope for something, right? And again, it's just love. It's loving one another, and it's loving our people regardless of what they look like, what they smell like, how they talk, any of that. None of that matters. When they come to our doors, they're humans, and we treat them accordingly. Period. And it's important, harm reduction is important because of all the things that you heard tonight. It works. There's research. There's years of research about it. It works. If a person doesn't, if you walk into a wall and it hurts, you're not going to continue to walk into that wall, right? So if you come into our program and get supplies from us and get a smile from us and get maybe a hot cup of soup from us, you're going to continue to come back because you didn't walk into that brick wall. People cannot get help if they're walking into a brick wall. They can't get healthy. They can't get what they need. And I think that is a really big point, that we just love each other. And I'm just all about love tonight, so you're gonna hear me say it a million times. But literally, it's just really caring for one another without judgment. And then the gaps, the needs and the gaps. I'm gonna be very frank when I talk about the needs and the gaps in our community. And so for me, I see folks that are suffering tremendously, folks that are unhoused, folks that don't have basic needs, okay? And when a person is offered housing, but they have to not use or test negative or not have access to sterile supplies or Narcan, you're asking a person to choose over their health or to choose over a place to live. And if anybody in this room understands substance use disorder and understands the hold that it can have on people, it's not that damn easy just to say, okay, I'll stop because I need to get housed. It's not gonna happen. You have to support people through that. And so a need in our community is to have the leadership from the top down support harm reduction. And so I am a true believer that all of the services that are provided to people in our community, shelters, encampments that are ran by city and county, any kind of rooms that are rented out to people on a monthly basis, anything like that, we need to embrace harm reduction and we need to support harm reduction, not talk the shit about here's harm reduction, we support it, but action, do it. You can say all day long you support harm reduction, but your actions will tell you if you do.
I think now is a question for Alexis. What is medication-assisted treatment and how do substance use navigators support people who want to enter treatment? What treatments are available for people who want to kick off or reduce drug use? What are the challenges?
So MAT, Medicated Assisted Treatment, is a program that assists patients who are seeking treatment within addiction. So within the hospital setting, what we do is we assist patients who come in withdrawal or overdose, who are either looking for opioid assistance, alcohol, methamphetamine, any addictions they receive, and they're looking for treatment. So what that looks like is starting within the hospital setting. And so what we do is we provide resources regarding treatment options. If it's opioid, we usually suggest buprenorphine, which is also known as Suboxone. It helps transition a patient from hard opioids to transition then into sobriety. What it does is it removes withdrawals and cravings, which assists that patient, because if anyone has experienced a withdrawal, it is very uncomfortable, and no one really wants to start that process. So when they return to us in the hospital setting, usually it's because of an overdose. We do get patients who come in withdrawal, seeking that assistance. So normally what we do is we come in, we assess the patient, and we provide that resource. If it's alcohol use, we do provide that resource as well. And so we start the treatment within the hospital setting, and then I bridge the patients into the community to continue that treatment. So there's no gap in between for that relapse, and they are provided with resources, behavioral health counselors, to continue that support and foundation. And it's a program that is specific to that patient's needs. It's not what a book tells them that this patient needs this, so it's for everybody. It's not universal. It is specific to a patient because every person is different. My specific role is to provide that resource, to be an advocate for those patients coming into the hospital setting, to remove the stigma, and to show the patient that they're not alone. I've had many patients I held hands with for hours and defended them with physicians or nursing staff who are unfortunately not on the level they should be when it comes to being humanized to the person at need. You know, we see somebody who uses heroin or fentanyl, methamphetamine, or any withdrawal for alcohol, and they're immediately stigmatized and judged. And mostly those people need is a helping hand, and that is in the substance use navigators within the hospital settings. And we provide that care to remove that stigma, and the culture hopefully will transition with it in time, and then transition them into care and the community with support, not just for them, but the family members and friends that are as well suffering. And the struggles that I can speak on within the hospital setting is, you know, we don't have enough resources for our patients. We do not have the treatment that is needed for them because they don't have the finances, they don't have the insurance that is accepted to cover their treatment, to cover their medications. And so a lot of our patients, you'll see, just kind of feel hopeless, and it's hard because our county at this moment does not have those resources to provide, and it's heartbreaking to tell that person, I can help you here, but once you leave, I can't help you anymore. So finding those resources is really where it's difficult. And if the patient is homeless and does not have a cell phone, then you lose that patient until they return again, if they return again. And so the goal would be is to provide all resources, regardless if you can afford it, if your insurance pays for it. We are here to help. And so I'm here to spread the word.
Are you speaking us? Or are you speaking us? Okay. Government employee. What is the current landscape in California? And then what's the human? What are safe consumption sites, overdose prevention centers, and how does drug checking help people who use drugs?
Yeah, so I'm going to spend a bit of a majority of the time to talk about the current landscape in California in regards to drug using trends and available harm reduction services in California, right? Yeah, okay, I'll talk a bit about that. So I'll first start off with ways that the Office of AIDS supports harm reduction services, supports syringe service programs. Fun fact, instead of syringe service programs, I think it would be really beneficial when we're thinking about informing the general public, when we're thinking about educating folks about a public health strategy, to call it harm reduction services, because when we say syringe service programs, we're limiting the available services that programs provide. So fun fact. So in regards to drug using trends in California, what we're seeing because of the presence now of fentanyl in our illicit drug supply, we're seeing a shift of people who traditionally injecting black tar heroin, shifting to smoking fentanyl, and also smoking methamphetamines, primarily, or stimulants, primarily meth. And, it's interesting when you're thinking about informing, because that is one of my roots, is to inform and educate. When you're trying to inform folks about harm reduction services, and we're talking about syringe services, people are still kind of stuck at the syringe, when a lot of programs now, a lot of harm reduction programs, there are over 70 harm reduction programs in California, in about 60% of California's counties. So harm reduction services are here. They're here. And they're making an impact in regards to new HIV infections among people who use drugs. So when we're thinking about harm reduction services right now, and we're thinking about trends, people who are most utilizing harm reduction programs are experiencing homelessness. They are also seeking smoking supplies or non-injection supplies, and also too, outside of the actual receiving drug-using supplies to prevent their risk, they're actually seeking HIV and Hep C testing. That service is the most in-demand service outside of actually, the exchange of supplies. So when you're talking about people who use drugs, it's like, let's take a moment and define people who use drugs. That's a general term. Everybody uses drugs. You drink coffee, you drink caffeine, nicotine. So it's like when we're thinking in this context tonight, when we're talking about people who use drugs, we're talking about people who are experiencing homelessness. We're talking about people who have minimal to zero support and resources to even take that step in thinking about the next move, right? So I would like to share that. Another trend as well that's happening in California, what we're seeing when we're talking about the California Harm Reduction Initiative. So that is one of the ways that we at the Office of AIDS are supporting programs. It started off with 15.2 million, and we were able to, after an advocacy win, an advocacy of people who work harm reduction programs, researchers, public health advocates, after a successful advocacy win, meaning going to Sacramento with banners and after a successful advocacy win, we were able to get the largest investment in California specifically for harm reduction services. So that funding paid staff to do the work. The average harm reduction program does not have an operating budget. The average harm reduction service program are volunteers who work out of the trunk of their car because they see a need to protect the community. So I just want to say that. And something else too in regards to how CDPH supports harm reduction services. We have the power to authorize programs in the state. So an entity can get authorized to do certain service programs, to do the distribution of drug-using supplies via local. They can get local authorization, whether city or county, and they can get state authorization. So that it comes in handy when there is a program, an organization who is in a community and there is a need. Oh gosh, we missed. And there is a need, and they're experiencing a lot of opposition in launching services and getting those services. So at the state, we're able to authorize programs. We also have something called the Harm Reduction Clearinghouse, where we provide harm reduction services or harm reduction programs with the supplies needed to get out into the community. We also provide direct funding, which we mentioned, Cheery, which is now the next iteration of that is called the California Overdose Prevention and Harm Reduction Initiative. So we've shifted from Cheery to COFRI, and that went from about 14 million to the 60 million that you mentioned earlier. And so that's another way, and then of course policy and providing technical assistance, that's how we support. So again, in regards to drug using trends, going back to that, I think it's really important for the sake of tonight the major takeaways is to know that when we're talking about people who use drugs in this context, we're talking about people who have minimal to zero resources. So let's just say that. We're also talking about the fact that there's a shift from injecting to smoking. So for those in the community, if you know someone who is still trying to wrap their head around a syringe, say, hey, you gotta catch up. We're now talking about not injecting as a means, as the preferred way of using drugs. And also too, just thinking about the implications of the racial implications, we, meaning Black and brown folks, indigenous communities, we're still significantly, disproportionately affected by fatal overdose. Yes. And
one line on drug checking, because it's becoming a thing.
Yeah, so drug checking. When we're thinking about, I like to always, when I talk about harm reduction services, I like to think of like this line. We are now accepting Narcan. Naloxone is now an accepted form of harm reduction in the general community. I know y'all remember when Narcan, people were like, Narcan what? Naloxone who? You wanting to do what? Without a prescription? Now it's an accepted form. It's a harm reduction intervention. It is a harm reduction intervention. Naloxone is accepted. Now we're thinking about drug checking. There's drug checking. We mentioned fentanyl test strips. You mentioned now we have xylazine test strips. And that is also a form of drug checking. There is another form of drug checking that is becoming, that's increasingly happening in California, where it's called spectrometer testing, where you actually you're able to have a machine and you can get a sample of your drug supply, and it can be tested, and it will have every type of drug that is in that sample. So I think that's what so that has become something that's growing in California. Like if we're thinking about the trajectory of harm reduction services, thinking about the trajectory of drug checking, there are programs that are starting to do that level of drug checking. And when you're thinking about the epidemic that we're experiencing, it is not we say fentanyl, the media says fentanyl a lot. What we're experiencing is a crisis in the illicit drug supply. We don't know what's in the drug supply. It's not regulated. So when we're talking about fentanyl, when we're talking about the fatal overdose epidemic, when we're talking about the fact that people are dying, what we're talking about is the fact that we have an unregulated drug supply. So if you're thinking about that, and thinking about the spectrometer drug checking, where you have this machine that can be mobile, that can go, I believe in San Francisco it is mobile, I believe also in San Diego, I think it is mobile as well.
And Los Angeles.
Thank you, and in Los Angeles, where they are able to implement that into their services and have another means of giving folks information about what they're using. Illicit drug supply is what's causing the deaths. Now there's an opportunity for folks to know what is in their drug supply beyond a test strip.
So we have one more question. Everybody's going to answer the same question, and then we want to open to the audience. How does that sound? We're doing good with time, right? Thanks to Texas. Give an applause to Texas. She's doing the time checking. So, and you have 3 minutes, so this one is really to be really focused. Given the alarming numbers of fentanyl-related death, how can the community, county, state, federal government support efforts to decrease the number of people dying? If you have to choose one thing, what would that one thing be? One thing that you think community, county, state, federal government can do to decrease the number of people dying? Because she has the mic. Because she's Lori. Oh, Lori.
Only one thing?
I think so.
Okay.
Choose the county.
Okay. So I'll think smaller and choose the county. But I think it also is going to go up all the way up to the state and the federal government as well. But I feel that for fentanyl overdose deaths to be eliminated or to get them reduced, what has to happen is people have to embrace harm reduction. People have to acknowledge that people use drugs, and that even if you tell people they shouldn't use drugs, people are going to still use drugs because it feels good. You can't tell somebody not to use drugs when what they're doing feels good to them. So accepting that this is the fact, that this is the reality that we're living in today, that has to be said on a county level, on a state level, on a federal level. It needs to be said that if we don't support people who are using drugs to stay alive, we're not going to be here. We're not going to have the next generation.
Very nice. One is very difficult, but I would specifically state for Sonoma County, I think one thing that would be extremely beneficial is having the appropriate resources for the patients who are seeking treatment to prevent them from relapsing and overdosing on the streets with no one around, no family, no one to notice that they haven't been in contact for several days. So I would say the resource that would be extremely beneficial is having county resources to support the patients or residents who are seeking treatment.
And just for my clarity, so in Sonoma County, buprenorphine or methadone are not covered unless you have medical, is that correct?
So for Sonoma County, for Sonoma County, you can receive that medication within the hospital setting and be dosed with it, but a doctor is very, they're not really willing to provide a script to then transition into the community. If you do not have Medi-Cal or any insurance, community clinics aren't likely to provide you that resource until you are insured.
Thank you. And the reason why what Dina says is so important, when people talk about treatment, they don't know that treatment is not supported, subsidized, or covered. So there's all these discussions in the state about treatment where many counties in the state of California, there is no such coverage. So applause for Dina.
Okay, so in terms of what can...
You cannot talk about the state because you work for the state.
So what I'd like to do, I'd like to start off with ourselves, right? I'd like to start off with ourselves. We're thinking about ways that we can contribute to address fatal overdose epidemic is to, the obvious is to educate yourself. Something that I like to make known is that, there's opportunities, we have the worldwide, but there's opportunities to learn and educate, to educate yourself on drug use in general. You mentioned drug use. People use drugs because it feels good. People use drugs because it's their way of healing, because it's their way of addressing trauma. It's their way of numbing. It's their way of medicating, and as you're talking about escapism, escaping pain. And recreational, yes, and to feel good, right? So just understanding the different types of drug use. I hope that makes sense. Like getting that foundation of informing yourselves. And then two, we are here, y'all are here for a reason. You're here because there's a connection to what we're talking about. And if you have a connection with someone who is using drugs, helping that person, starting with that person. It can be, hey, reaching out to you twice a week, reaching out to you every other day, having that human connection that what you were talking about, Lori. So in terms of ourselves, like just as a being, what we can do to contribute is to inform and is to connect as well. And from a county perspective, when you're thinking about the, I call it the trajectory of harm reduction services, figure out where the county's at. We all talked here about syringe service programs, about the distribution of naloxone, about the distribution of drug using supplies, of non-injecting drug using supplies. You talked also about treatment. There's California Bridge, meaning that there are treatment options 24/7 in the emergency department at a county hospital. You're also talking about providing basic needs services for people who are experiencing homelessness, right? So it's like thinking about the trajectory. On the very tail end of that spectrum is safe supply, a conversation that a lot of folks aren't ready to talk about. And that is okay because you can gradually just get to a happy median. So when you're thinking about naloxone distribution and scanning the community and figuring out where community-based naloxone is happening, where are the gaps around that? Figuring out the gaps. Are they available at the hair salon? Is naloxone available, at the gas station right next to it? So just thinking about ways to increase what's already happening or strengthening what's already happening. That's a good strategy to address the fatal overdose epidemic, and just understanding that it's small incremental steps, not leaps. Small incremental steps when you're thinking about yourself is figuring out how I can make that connection to someone who I know who was affected. Yes.
I read that Kaiser now, every prescription they give of opiates, they give Narcan. So why can't we have every drug dealer, when they sell drugs, give them a box of Narcan? I mean, it sounds kind of simple. We would have to find the drug dealers and educate them. My son was in a really nice home in Novato. He wasn't on the street, and he thought he'd just have fun. And that drug dealer did not have Narcan and left him there when he was passed out. So there's a room for education there with the people that are distributing the fentanyl.
Thank you. Can we give a round of applause to entire panel? right, we're doing great. So we would love to invite questions from the audience, and I'm more than happy to bring the mic. And it could be directed to someone, or you guys direct it to a crowd.
Thanks for sharing everything you did with us. My name is Bob. I'm a student at the JC, studying substance abuse disorder and counseling. A couple things, you mentioned, I think it was Laura, mentioned safe supply. And I recall reading in one of my materials for my course that in Switzerland, there was a period of time where the president did an experiment and actually allowed prescription heroin. And it actually saved a lot of lives because it was not adulterated with any other contaminants. And when the experiment ended, people continued to fall like flies because of the contaminated drugs. And I don't know if we could ever get to that point, but that might be a bridge to try to get to at some point in time, whether it's an experiment or a real deal. So that's just a question. And then, there's a huge crackdown now going on down in the city on dealers. So I don't think you're going to get any of them to come forward to get nothing, unfortunately. But I'm wondering how that crackdown is going to affect the people who are addicted and need the supply. Are they going to go through terrible withdrawals and maybe suffer from that?
Thank you for sharing that, and you did mention that you are currently a student learning. I highly recommend, not just for you, but for others in the room, a book called Chasing the Scream.
I just got it because of you, Lawrence. I just got that book, yes.
I strongly, those who like to read, it's also available, I think it's Audible, or, yeah, you can, there's ways you can listen to it as well. But the book is called Chasing the Scream. I'm sorry, but I don't remember the name of the author at the moment. But that is a good starter for anyone who wants to take a deep dive into the why we're here. And just one quick comment that you mentioned about safe supply. Again, when you're thinking about the trajectory and thinking about, let's talk about the United States at this point, right? That is a big leap. Unfortunately, it shouldn't be. So let's talk about overdose prevention sites. When you're talking about overdose prevention sites, you've probably heard this in the media. They call them safe injection facilities, or what they call them, drug consumption spaces. And being that I heard the Office of AIDS thinking about data, technical, the data shows that when a community has an overdose prevention site in their community, the number of fatal overdoses drastically decreases. So I will leave you with that. Safe supply, yes, it is quite a leap. Overdose prevention sites, though, it's not quite a big leap.
But can I say something about heroin, the heroin maintenance from Switzerland, which, by the way, Canada is also doing it. Vancouver has been doing. It's not heroin, it's dilaudid, so it's not the same white substance. But what we do know is that, again, for the patients that have been using this clean, quote-unquote, clean supply of dilaudid, they tend to maintain, or actually in Switzerland, people gave up. They were sick and tired of having a clean supply of heroin. So we do know that it works for certain people, right? And then the other thing to say about safe supply is, this country talking about distributing heroin, cocaine, I mean, it's like the empire goes down, right? It's like we cannot open an overdose prevention center. But we firmly believe that without safe supply, this drug supply is not going to get less dangerous. It's going to get more dangerous. So one thing we know is everything that is happening now is being manufactured. We're not seeing tar. We're not seeing heroin in California because in Mexico the poppy has been stopped from production. All there is cookouts of fentanyl. So we also start seeing PCP in the drug supply. That's what drug testing is important. What we were seeing in California Harm Reduction initiative in sampling people on, the folks were telling us, actually they were better knowledgeable about what was happening in the drug supply than anybody else that was talking about it. So we know that now with drug testing, we see what else has been added. So there has been samples of PCP in fentanyl, cocaine, and heroin in San Diego in the last couple of weeks. So the drug supply will get more dangerous, not less dangerous. So I think your point is well taken. I want to address the issue of incarceration because in San Francisco, since Mayor Breed has been incarcerating drug users and small dealers, we have an explosion of the jail population, at which half of them are Latino immigrants. So I wouldn't be surprised if Sonoma will be taking that unfortunate track because it does not reduce overdose death, it just criminalizes Black and brown folks as we've been doing. But we're very concerned. We're actually starting a big coalition in San Francisco to stop this nightmare. So is that happening here too? You were talking about Sonoma or you were talking about San Francisco? That's my favorite city in the world right now.
The crackdown I've been referring to is the one in San Francisco on the dealers.
Yes, yes. So we have 1,200 people all of a sudden in jail after we have closed the jail in the last 2 years. And out of that, half are Latino immigrants. The majority are Hondureños, a large number are minors. That's the population of the jail in San Francisco right now. It's outrageous. And you have your hand?
No, I was just going to say what will complicate the situation is that the state, I mean, this kind of comes into play is that the state is going to start enforcing care court, mandating people to go to rehab.
Right.
And that's going to be really problematic because rehab has to come from the person, right? They have to want to make a change. And I think that's a recipe for disaster, and it's a concern because I work in mental health in response, and so that's really going to change how we work with people out in the community, and I'm worried about the repercussions of that.
There's it's kind of like a cycle. I'll be brief, loud, I swear to goodness, I'll be brief.
You and I are alike.
So, before fentanyl was really prevalent, before it was prevalent in California, but it was still black tar heroin, crack as well. We had, a very, our approach was punitive. We had a punitive approach. Fentanyl hit, and there was a New York Times article that came out some years ago that said the change, like the face of the drug epidemic has changed, right? To someone who is using prescription pills. It changed from a black or brown person of color to a white person who is, using their parents' pills. So then when that happened, that New York Times article came out and it caused a lot of stir, a lot of other media outlets picked up on it. And then there was a lot of calls, advocacy happening in DC around changing the approach to be less punitive and more, and considering people who are drug use or the fentanyl use as more of like a public health perspective of meeting someone of addressing the need from a public health perspective. It's shifting again, and it's shifting again to more now going back to like that criminal base when you're thinking about San Francisco, when you're thinking about even what we're experiencing at the state level of going, I'd like to say it's kind of like going backwards, where we have used the same strategy, we meaning the United States, we can even trickle down to California. We use the same strategy, but we're still having the same problem. And there was like this one moment that happened when folks decided, no, we need to have a more like public health approach to this. And then it was gliding for a bit, and now it's like we just went back to this criminal-based, punitive thing. So I just want to say that. And then the other thing too is that fentanyl is here. There's talks about xylazine. When you think of a drone and you're just pulling out, and you're getting a large-scale view of we're going to have this happen again. There's going to be a different drug. There's going to be something else that's going to get introduced into the illicit supply that's going to cause harm. Consider that when you're thinking about what has been done in the past to address and what has worked and what has not worked, and thinking about ways to make sure that when it happens down the line, what tools worked, what didn't.
Just one quick thing on the care courts is that there's not enough treatment, so they're either going to have to use all the treatment for mandatory treatment and leave the people that want treatment without treatment, right? Which is what we do in this town. Not in this town,
I had a question for Alexis at Memorial Hospital. Is there any chance of doing educational things for the providers there, especially
actually-
for ER physicians?
Yeah, sorry to cut you off. Actually, yes. So when California Bridge initially started the substance use navigators within the hospital setting, they required the physicians in the ED to take mandatory trainings on how to start buprenorphine inductions. So they were required, it's called an X waiver. However, due to COVID, they no longer require an X waiver for a physician to start that medication. We do recommend it, especially if the physician has never worked with that medication before.
It wasn't so much about, just about drug addiction in general. I mean, it seems like there's that nursing humanity that needs to happen there. But, I mean, don't they have a lot of precipitated withdrawal then if they're giving people Suboxone who are using? I mean...
So that's a good question. Precipitated withdrawal is...
Yeah, that's what I'm saying. So are they doing macrodosing, or do you know about that level of?
They have to do it.
So initially... No worries. So when a patient comes in, so what we do is we do an assessment on the patient and when their last use was. And so that initially will tell us when that patient is available to start an induction in the hospital setting to prevent precipitated withdrawal. So we do try our best, but also it comes down to the patient at hand being honest with last use.
Right. Well, I'm over at Centerpoint Daiquiri, and so we've got people who might like to be on Suboxone, but they've heard so many horror stories about precipitated withdrawal, they're not willing to get near it.
I would love to meet with them, and I'm more than happy to speak with them and help them with that transition.
Thank you.
Thank you. Who else was I saw there?
Kind of ignorant in the sense that we're changing over from injection to smoking. So you would think if people were smoking, they wouldn't have as much overdose because you're not doing a huge thing at one time. So is that true? Is that showing, or is it just people just smoking too much? Is my question. I just don't know. Want to talk about our study?
I can give you some information on that, then I can pass it over to the state.
Whoa, I love that paper. Where am I going? This is playing beautiful. It's called liberation from the state. This is
Okay,
beautiful.
so as far as a person can still overdose regardless how the drug is getting into their system. It's the amount of time that it takes for that overdose to happen, whereas if a person is injecting, it gets in the system a lot quicker, where the overdose can happen pretty quickly. Sometimes with fentanyl, the needle is still in the person's arm or wherever that injection is taking place. With smoking, it gets in the system quicker as well, but you have more, it gets in your system as well, I meant to say, but you have a little more control over it because you have a little bit, you could take one little small hit, kind of see where that's going, and then no. But you can still overdose with smoking, absolutely.
Do you want me to talk about the study, or you want to talk about the study? So, to your question, we did a study paid by the state in collaboration. So our California Harm Reduction Initiative had a series of point-in-time surveys that we did on the street, and the fourth one we attempted to do it with a very prestigious research group called RTI International. They were the ones to start seeing this trend in San Francisco. So we took PIT 4, we partnered with them, so our data collection was much tighter, and the study's about to be put off on big research field, but the study shows that actually people who smoke versus inject have much less, and I can't remember if it's 2-to-1 or 3-to, I can't remember the ratio, less incidence of overdose, not overdose, overdose, than people who inject, and of course the correlated non-other factors, like infection, tissue infection, etc. So we think that our study, which is probably one of the first that has been done in this manner, is going to create a lot of excitement and discussion, because it shows two things also. Typically injectors of heroin, we're not transitioning to smoking no matter what a harm reductionist will say. And we try, believe me. We try with youth, we try, there was a program in San Francisco called the UFO, trying to work with youth to transition from injection to smoking. And very few folks did it. But it happens that with fentanyl, this might be a natural way because of the challenges about injecting. So that's what we presume is true, which might be combined with what Laura is saying, but we're very excited about that data that we have collected, and it will be published very soon.
And the Harm Reduction Journal just released a literary review that was released about 2 weeks ago, where they compiled data, they compiled research findings from about 38 studies that was done about smoking, or the transition from injecting to smoking. And what the preliminary findings, what they found is that, just what you're saying, that, and what you were saying as well, that people self-reported that they're able to control the use more, less soft tissue infections, and less incident, like general overdose incidents, not fatal, just overdose in general. And because when you're thinking about trends, and then you're thinking about research, and you're thinking about government, we're still playing catch up, believe it or not. And so there's research, there is a building body of research that is supporting the benefits of smoking than injecting. And the Harm Reduction Journal, I think it was October 27th when that study was released. You can look that up online.
I just had a question about any work that might be happening with harm reduction in the homeless community. They face, extra people without ID, without an address, without transportation. It just makes the issue so much more complicated.
I'm not sure if I understand your question. Could you repeat that, please? Just from the beginning piece.
I was just really interested in if there is any outreach or any kind of programs that are reaching out and trying to address the issue of addiction in the homeless population.
I'm so glad you asked that question. I thought I heard it, but I just had to hear it again. Yes, we have Face-to-Face and other harm reduction organizations in our county have tried to get into several of the encampments that are, I guess, called sanctioned encampments. And we have not been welcomed to those locations. But in harm reduction, that doesn't stop us. We still go. We just go outside, and we go in the areas where the people will come to us. But that's a barrier for people to access services. And that is definitely something that is happening in our community, and that is something that we are fighting to go somewhere where we're fighting so that we can get into those locations to serve those individuals. Hey, I don't have a problem saying anything, okay? I hope the Press Democrat's still here too. So, literally, like with the DEMA camp, I'll just speak it like it is, no elephant in the room today. With the DEMA camp, we have tried over and over to get into that location and provide services to the individuals there. We were not welcomed there. Again, like I say, that didn't stop us, we still went there, but then people were getting threatened with getting kicked out if they seen people coming over to our location or our van or talking to us. They were getting searched when they were going back in, and if they had supplies on them, they were being punitive, they were being getting in trouble.
Who manages the government?
DEMA is the name of the camp. And it's a county-sanctioned camp that Sonoma County oversees. So the county funds DEMA to oversee that camp.
Are they religious, or is there any other DEMA problems?
They are not religious, but they just do not support the fact of harm reduction. Again, it's going back to that question that was asked around enabling, and I think some folks that work there have their own personal experience with substance use and believe that that's enabling people to use drugs, which we know is not. So because of the non-welcoming of us being able to come in now and before, and probably tomorrow, is people are suffering that are there. There's overdoses that are happening there. There's infectious diseases that are being spread. There's people who are not being treated with respect. There's just, I mean, it's horrible of what's happening in that camp. And there's other spaces in the county that serve unhoused individuals that support harm reduction. We go into those locations and provide these services. So it's not something that can't take place. It's not a rule or a law or anything. It's just they don't support it.
And just to answer, during COVID, most of the SSPs, the syringe service programs, harm reduction services, were the only ones throughout California serving unhoused people. When other outreach programs stopped going outdoors, our SSPs were opening bathrooms. They were doing hot dogs, and they were doing sandwiches every day. So actually, our PIN count, what we're talking about, this survey, shows that 70% of all harm reduction service participants in California meet the unhoused definition under HUD. So we are serving primarily unhoused people throughout California.
Yeah.
But for PIMA. PIMA is called?
DEMA.
I'm going to investigate them. The state should investigate too.
It's an acronym. It stands for Disaster Emergency Medical Assistance, and it was a consulting agency that came about during the wildfires, actually.
Oh.
It's a disaster evacuation.
They're cousins of FEMA. That's what they're called, FEMA.
But yeah, and now,
So PIMA.
and because they have now that infrastructure from the wildfires and from COVID, because they're a disaster management service, now that they have been awarded this contract.
Yeah.
The state should get involved.
Can I say something to her question? I don't speak for face-to-face, but in a hospital setting, when I do have unhoused patients, I do provide them resources with social workers and nurses, registered nurses, when they do transition to the community to continue treatment and to assist with whatever resources they do need. On behalf of DEMA, I am very familiar with them. I do actually participate in attending a lot of their facilities because I do have a ton of my patients staying at those sites. I can't speak on Lori's behalf and her experience, but I do know that they are funded to also provide resources for patients who are suffering with substance use disorder, and they do not. So patients are able to continue use on sites, which then provide them for overdosing and sending to the hospital settings. And so from my experience, they're not providing the resources they are being funded for, therefore they kind of keep at hand on the people who are actually trying to provide those resources.
If you look up Press Democrat and DEMA, you'll find the answers you need.
So Press Democrats still here? What time is it? It's still not. Okay, I think we have maybe one more question. Anybody? Question, comments?
Hello. I guess I have a broad question for everyone here and everyone up on the stage. What is the best way that an individual in the community can get involved aside from just educating themselves? Who do they reach out to if they want to help promote harm reduction, whether it be volunteering with harm reduction sites, or if they want to spread literature or act as a liaison within the community and their community to help set up these vending machines or whatnot? Where does the average person go to help?
You can definitely contact face-to-face. I have business cards in the back. We do take volunteers, and really it's if you spread the word and provide a person the steps to reverse an overdose, you are potentially saving lives. So like just spreading the knowledge that you have. But we do have volunteer opportunities. Grab my card in the back and then email me, and I can give you some more information.
Hi, I'm not sure this is a controversial question, but I heard a lot about stigma being discussed tonight. And I've also read research that the University of Amherst did a study that determined that mortality rates in states that have legalized cannabis from a recreational point of view have seen opiate mortalities drop 20 to 35%. What is your view of cannabis as a pros and cons, as something that is a gateway drug into this or a gateway drug out? What is your role and view of cannabis as a solution or a problem?
So thinking about cannabis, I'll be very short. Thinking about cannabis in the context of a person needing to use a substance to self-medicate, to deal with trauma, so the harm reduction aspect of that, the data shows, right, that it can help someone, that it can help. The data shows, the research shows that it is something that is beneficial if someone wants to do that. I'm trying to like keep that government hat on without being like, oh yes, I love cannabis.
The state is watching you.
And, you know, like, I would also, I will be the
He works for the state too, so he's watching you.
So, I'm a harm reductionist, okay, and I believe that any risk reduction that a person takes is beneficial to them, okay? And if a person wants to smoke marijuana to help with pain, I think I'm for that. I'm good for that. I think that that's a legitimate medication that helps people. I, in my personal life, have family members that have used medicinal marijuana that has helped them. So I've seen it firsthand, and I know that it works firsthand. I do not believe that marijuana is the gateway drug. I don't know any pot smokers that are stoneheads when I was a kid that all of a sudden started smoking weed and then started injecting heroin. Like, it doesn't happen like that. So that's a myth. That it's a gateway drug. It really isn't. It's just a scare tactic that people use to try to scare people from even use smoking pot. So all I can say is, if pot works for you for medicinal purposes, go for it.
And my other addition is that we have found that certain forms of cannabis, and in particular CBD combined with THC, do they're more impactful in neural pain than opiates. So I do know that for some people, actually, that transition is very important, because then you can take care of the neural pain instead of being, always constipated with Oxycontin or whatever the doctors give you. I also know, in working with meth users for a long time, depending on the strain, right? The great thing about California is that we have great weed. So there are strains of cannabis that are really, for some people who use speed, that have been successful for them to transition out of speed. I mean, we haven't talked a lot about meth today, but it's the most used drug in California. Most people use meth over fentanyl. Probably not over cannabis, but we don't ask that question because pot is legal. But I want to say that there is many other evidence in which cannabis can be an incredible substitute as people are trying to transition out of certain substances. So,
Can I just say, there's a difference too between somebody using marijuana medicinally or edibles, which can get into trouble too, if you the high concentrate, but like wax or dabs, that can be a different thing for a new user too, than actually smoking the flower or a vape pen or that kind of thing.
yeah, we have so many ways. The only other thing I was going to add is I was just in a drug policy conference where the conversation has started about people who are transitioning out of opiates used in psychedelics. And so there's a whole, oh look, Gavin just vetoed mushrooms. Did you guys know that? He just vetoed the legalization of mushrooms in California. He has a problem with drugs. He always did. But I'm from San Francisco, so I dealt with Gavin when he was the mayor, believe me. I can say that because I don't work for the state. But psychedelic, there's a lot of promises around mushroom and LSD and, more therapeutic uses of psychedelics. So I know that some folks are starting to use that. In fact, in Mexico, in northern Mexico, there is a clinic that serves Yaqui community who have been impacted by meth, not by opiates, and they transition out using traditional healing psychedelics. So it's a great question. So let's give an applause to all of you for your amazing questions, to the panelists, and the President Sarah for closing.
Wow. Oh my goodness. Thank you so much. I mean, this has just been incredible. We learned a lot today. I hope that you're feeling enriched and empowered to go and take action. I mean, I think one of my biggest takeaways is let's stay connected, show some love, see what you can do. I mean, this is a community response, and this is our community. So thank you for being here tonight, and thank you for all you're doing. And I get emotional too. We have a reception, so please feel free to stay. If you're interested, if you want to get connected to Face-to-Face, we have information, as Lori said. If you'd like to donate to Face-to-Face, we have donation envelopes back here. But please stay and talk and connect, and we have some wine and some cheese and some snacks.
And naloxone.
And naloxone. Take some Narcan home. Everybody take Narcan home.
Can I do a plug for you guys? I'm not a panelist. My name's Carrie. I'm a Sonoma County native person. I'm from here. And 10 years ago, I was a volunteer at Face-to-Face. I actually worked with Lori. We did Hep C testing and HIV testing together in the mobile van. And I learned so much from Lori. And Lori has just been one of the most amazing harm reductionists I've ever met in my life. And just for what it's worth, I moved to San Francisco. I live in Oakland now. I actually work for the California Department of Public Health now with Horace. And I've also been in community without him, and I've also established my own naloxone distribution program independently in San Francisco, but I would not have been able to do any of that if it wasn't for Face-to-Face. So I want to thank you.
That's so sweet. Thank you so much, Carrie. Please take Narcan. If you don't know how to use it, I will show you how to use it right here tonight. It costs a lot of money, so don't waste it, but take it and use it.